We are live.
Yes, I'll start my presentation. Welcome, everybody. Good evening, my dear colleagues. I, Dr. Anil Shah, President for Maharashtra chapter, welcome all of you to this wonderful series webinar that is A to Z of manual small incision cataract surgery. Today is episode 20. The title for today's episode is From FECO to SICS, When, Why and How. The aim of SICS webinar is to popularize SICS by series of webinars to enrich our knowledge, to emphasize how SICS is safe, cost-effective, with minimum learning curve, to emphasize its usefulness for community basis, to involve expert surgeons to share their knowledge and experience, and to make SICS interesting and a popular technique. Here are few important quotes for this topic. Technique is important, but outcome matters more. Choose the method your patient needs, not the one your ego prefers. Every surgeon should have more than one arrow in their quiver. Knowing both FECO and SICS make you ready for everything. Mastery lies not in choosing between FECO or SICS, but in knowing when each serves patient the best. The best surgeon is not one who always uses latest tool, but the one who knows when to use which always. Here are a few images where FECO needs to be converted to SICS. And for this webinar, we have chairperson Dr. Prakash Marathe, Dr. MD Mizanur Rahman, and the speakers for this topic who are expert in their field with the best of their knowledge and experience, Dr. Suvira Jain, Dr. Deepak Megur, Dr. Pradeep Mohanta, and Dr. Chinmaya Sahu. And the discussion who will argue and debate and dialogue, Dr. Professor Manisha Rathi, Dr. Divya Manor, Dr. Anand Pangakar, and the moderator who will preside over a webinar making the discussion enjoyable and effective, Dr. Ruchita Majwe and Dr. Pankaj Shah. I am really very much thankful to all the chairperson, speakers, discussant, moderator for sparing their valuable time and making this webinar a grand success. Thank you. I'll share to Ruchita. She will continue.
Hello everybody, I'm Dr. Rujita Machwe. Am I audible?
Yes.
Yeah.
You are audible.
Yeah. I'm Executive Committee Member, ISMSICS Maharashtra Chapter, and I welcome you all for this episode 20 of our webinar series MSICS A to Z. So we have got plenty of webinars with fruitful discussions, and this is our 20th webinar, and I welcome you with all my heart. So to start with, at the outset, I will invite the office bearers of ISMSICS. We have got Dr. Usha Johari Madam, Joint Secretary and Chairman, Dr. Anil Shah, and Chairman Dr. Prakash Marathe Sir, and President Dr. Anil Shah Sir of Maharashtra Chapter. So I welcome you, Dr. Prakash Marathe Sir.
Hello, good evening, everyone. As the chairman of Maharashtra chapter of ISMSICS, I welcome each and everyone, respected speakers, chairpersons, discussants, and the most important, the delegates who are going to participate in this webinar. This is the fantastic series started by our President Dr. Anil Shah on A to Z of SICS. I always say it is not A to Z, but alpha, beta, gamma also. He has covered almost each and everything about SICS. And today's topic is really very interesting. Most of the times there is a little bit war about SICS versus FECO. It is not. Both the things are complementary to each other. But FECO surgeons, if they don't learn SICS, if there are some complications, probably it is very difficult for them to convert. But if they really know SICS, while doing FECO, if there is some complication and they want to convert, probably they will be able to do it. And there are masters in FECO surgery. As speakers today, they will be demonstrating their videos and how it is aligned with SICS and FECO in those situations, how they are tackling the situation probably will be demonstrated by them in a fantastic way. Dr. Mohanta is there, Dr. Suvira is there, Dr. Chinmay Sahu is there. Our office bearers of ISMSIS, Dr. Amulya Sahu, Dr. Boramani, and the team has been doing wonderful work across the globe. And I think the same has been continued here for all of you by Maharashtra chapter. So I wish all the success and all the best to this webinar today. Thank you so much for the opportunity. Over to you, Dr. Rujuta.
Thank you so much, sir. May I request now my co-moderator, Dr. Pankaj Shah, to introduce today's respected chairpersons and the speakers. Over to you, Dr. Pankaj.
Thank you. Thank you, Rujuta. I, along with my co-moderator Rujuta, invite and all of you, welcome you to this wonderful webinar where we have galaxy of speakers, discussants and chairpersons. It's an interesting topic. So to begin with, I start the introduction of today's chairperson. Is my screen visible?
Yes.
So,
Yes, Pankaj.
Dr. Prakash Marathe sir, who is the chairman of Maharashtra chapter of ISMICS. He is past president with vast experience. He has been a leader of Maharashtra Ophthalmic Society, Pune Ophthalmological Society, still active worker in IMA Pune and IMA Delhi also. He was a faculty at Installation of Australia, New Zealand chapter, and then he was joint organizing secretary for World Conference of ISMICS Kolkata 2019, recipient of various awards and still active and many things to learn from him. Welcome, Dr. Prakash Marathe sir.
Thank you. Thank you so much.
We have our active dynamic president of Maharashtra chapter of ISMICS, Dr. Anil Shah, who is quite innovative and has various instruments in his name, like very famous snare, which we all are using. Then he has been pioneer in using a large foldable IOL for MICCS. He has done modified intracystic implant for DCR. He has a Best Research Private Practitioner Award also. Welcome, Dr. Anil Shah, sir. And he is the key leader who has kept us bound and giving us the various topics to learn under these webinars. We have Professor Mohammed, sir, from Bangladesh. He graduated from Rajashri Medical College and he has completed his postgraduate training in ophthalmology from National Institute of Ophthalmology, Dhaka, and then achieved special training in macular diseases and treatment from Singapore. Currently is practicing anterior and posterior segment diseases, especially on cataract, glaucoma, and medical retina. Welcome, sir.
Thank you.
Yeah. Today's speaker, very renowned Dr. Suvira Jain. She is highly experienced senior consultant in refractive cataract surgery with over 25 years of experience. She is clinical head of cataract, cornea, and phaco development at Bachchuwali Eye Hospital. She is director of phaco training since 2005 and has trained over 900 students during this period. She has also done 90,000 cataract surgeries, phaco surgeries, and transplants also 500. She has been invited as a speaker at various state and national and international conferences. She is passionate about teaching, living behind a legacy. She is also co-founder of YouTube channel Phaco Point, which facilitates phaco training to ophthalmologists worldwide. One of the most dynamic, Dr. Deepak Meghur, whom we all know and love to see his videos. He is one of the speaker today. He heads the cataract and glaucoma department at Meghur Eye Center, Bidar, specializes in complex cataract surgeries, and he is passionate in teaching and sharing his skills through phacotraining.org and a recipient of various awards nationally and internationally. Dr. Pradeep Mohanta sir, he has done his graduation from Kolkata Medical College and post-graduation from PGI Chandigarh. He has been an humble beginning in a rented place and he is a founder of Netrajyoti Eye Hospital in Ranaghat. He is a comprehensive cataract surgeon and teaches both SICs and phaco to his trainees and has trained 100 international students and innumerable national candidates. His main mission is to make good eye surgeons so that millions of patients get good vision through thorough competent hands. Welcome Dr. Chinmay Sahu sir. He is a vitreoretinal surgeon and is a meritorious student throughout. He has completed his undergraduate and postgraduate from Nair Hospital and then retinal fellowship from Shankar Netralaya and worked at LV Prasad Eye Institute. She combines best of the two premier institutes and has a vast experience and specializes in management of complicated retinal cases, vitreous hemorrhage, and various other diseases like the complicated diabetic vitrectomies. He is also attached to Jaslok Hospital as a consultant. Welcome, sir. Now I hand over to Ruchuta for further.
Thank you, Dr. Pankaj. For any webinar to be fruitful and interesting, we have to have discussion. And for that purpose, we have invited renowned ophthalmologists, and they will make the discussion very interesting. They'll ask questions, give their inputs. So may I invite the discussants? Our first discussant is Dr. Manisha Rathi. She's Senior Professor and Head of Glaucoma, RIO PGIMS Rohtak. She's a member of Managing Committee AIOS from Haryana. She's a reviewer of AGO, IGO, Chairman and Judge in the upcoming AIOC APA Conference 2025. She has over 60 publications in international index journals, and she has received various awards like Gold Award from ISM SICS for outstanding contribution, Silver Plaque Appreciation Award, and Secretary's Appreciation Award from ACOIN. So I welcome you, ma'am. Our second discussant is Dr. Divya Manohar. She is currently serving as Medical Officer at Arvind Eye Hospital, Tanjavur. Heads Cataract, Cornea and Refractive Services. She is a high-volume cataract surgeon and has a vast experience in advanced refractive procedures like SMILE, LASIK, in addition to keratoplasty and complex anterior segment surgeries. She holds a micromasters in clinical epidemiology from the University of Michigan. She's also done the Accelerated Management Development Program from the Ross School of Business, Michigan. She has various publications on dry eye keratoconus ocular infections in national and international journals. Welcome you, madam. Our third discussant is Dr. Anand Pangarkar. He is MS Gold Medalist from JIPMER. He is Chair Scientific Committee IS-MSICS Maharashtra Chapter. He has received many awards like Innovation Award twice by MOS, Best Paper Award for CCC Kolkata Conference, he is honorary associate professor for past 25 years at IGGMC Nagpur. He is chair, judge, evaluator for MOS, JCOR, BOA, AIOS meets. He has presented papers at SARC, APAC. So without further ado, may I request our honorable speakers. The first speaker is Dr. Suvira Jain, and she'll be presenting on phaco conversion to SICS, surgical pearls and pitfalls. Dr. Suvira Jain, ma'am.
Let's begin. Good evening, everyone. I'd like to now share my few cases, and I'm happy to take either we can stop in between each of the cases, or I can go through the 4 or 5 and then we can discuss them. I'll begin now. So at this point, let's discuss today what are the various considerations when we need to convert a patient who's undergoing a phacoemulsification surgery to manual SICS. Now, when we talk about converting from phaco to SICS, it's almost always to either avert an intraoperative phaco disaster or less severely to manage a complication, something like explanting a lens. The biggest challenge is in managing to prevent something from dropping back into the vitreous, which is why we do need to enlarge these sections. But most important to start with is first to understand the technique of converting the phaco incision to SICS tunnel. We should have a technique that works for us. We should understand how to do it so that when faced with a disaster, we can act quickly, convert quickly in a good manner and be able to manage the case well. Let's start with the surgical cases. Here's the first case. A patient with a grade 2 nuclear sclerosis with a 5 clock hour of zonular dialysis. Following the rexes, I start to introduce CTR, and while introducing the CTR, I noticed that the zonular dialysis more than 8 or 9 clock hours itself. I still complete the placement of the CTR and plan to downsize and emulsify the nucleus, after which I plan to fixate the bag with the eMUD segment. The initial part of the phaco chop seems to be going well. I'm able to break down and bring one of the fragments out, and we know that when we get one of the fragments out, now we have room to work on the others. But at this point, I notice that when I'm trying to bring this fragment out, suddenly I do break it down, I emulsify the little bit, and after which I notice a shifting in the position of the rest of the nucleus. It's tending to tip down. There's a great possibility that my chopper has injured the PC and I've created a rent. So at this point, in order to salvage the situation, I now plan to convert to SICS. Now, I'm a superior sitting surgeon. That was my position of my main incision being left-handed. It's at the 65-degree angle. I also like to therefore make my tunnels in the superior plane. Now, my preferred technique of converting in terms of making the tunnel is making a SICS tunnel in a completely different plane. So I have a phaco tunnel, which is superiorly, and at a deeper plane, which I have planned, and I navigate the crescent to go and extend and create the tunnel for the SICS in a plane deeper, as you can see in this video. Now, once I've completed dissecting the plane, then I use a 2.8 keratome and I enlarge the tunnel. Now the challenge is I have a rent. I don't think there's vitreous. The nucleus looks stable. I need to get it out. So in a bimanual technique with the help of a 30-gauge needle hooked onto the needle, initially a Sinskey hook passed below the bag, CTR, and nucleus complex, I stabilize the nucleus. I bring it out into the anterior chamber. And once I've maintained it here, once more I put in a dispersive viscoelastic deep to the nucleus to keep the vitreous away. And then with the help of the vectors, I bring the nucleus, the CTR, out of the eye. Now that's one averted disaster. But clearly and most oftenly, you're going to have disturbed vitreous in a scenario like this. After staining with tricot, I now proceed to perform a limited anterior vitrectomy. My irrigation is held in my non-dominant right hand and with my vitrectomy cutter. Note how I cut the vitreous. Right now, I've gone in the IA cut mode to aspirate the cortex that has prolapsed out into the anterior chamber. Once more, I go into the cut IA mode and I complete the vitrectomy, after which, in this particular case, which was done almost 5 years ago, under air cover, I was very happy to put in an anterior chamber implant in the anterior chamber under air. I put it in. I slide the trailing haptic in, I maintain the pupil nice and round, and then hydrate the side ports. Because I want some more stability, I don't want to take any chances. I've taken incisions. And note how I've also bothered to hydrate the phaco incisions. This brings us to the end of case 1. Now here's another case done by a colleague of mine. He's working on a posterior polar cataract with a grade 2 nuclear sclerosis. The technique of choice in managing this would be a direct chop. The first chop has happened quite well. The second, the heminucleus is broken again further down into a smaller fragment. The first fragment has come up effortlessly and has been emulsified. But notice the length of the chopper. At the time this fragment was brought up, probably the PC has given way, and you can see a splaying away of the fragments signifying the possibility of a rent. Viscoelastic is then introduced, and I think it's important to remember that when you're trying to bring fragments out in a compromised case into the anterior chamber to bring it out of the eye, if you've got an intact nucleus, it's easier to bring it up. When you're left with individual fragments, bringing each of the fragments independently up can be challenging. Moreover, the smaller fragments are more easy to drop down should you have a rent that's large enough. In this case, with the help of a Sinskey hook, the surgeon has managed to get the fragments up. A dispersive viscoelastic is again injected deep to the fragments. Now, at this point, he wants to do something to just manage to enlarge the incision. So his technique here was virtually making side slits of the main 2.8 incision and cutting the incision open. So technically, this is not exactly a converting to SICS, it's just enlarge the incision. But truly, at this point, we've got to salvage the situation with the help of a vectors. And then, because the fragments are smaller, a visco expression of the fragments is tried. At any point when the visco expression doesn't seem to be working, the fragments are brought out. Here again, visco expression seems to be working. Again, it stops working. So once more, with the bimanual technique, the last fragment is brought out. Now, all this maneuvering of fragments into the AC and bringing them out of the eye invariably result in a vitreous disturbance. I personally like to always delineate the stained vitreous with the help of tricot because I'm aware and I'm sure I won't be missing any of the vitreous behind. And then with the help of a cutter and an infusion, first a limited anterior vitrectomy, and now in an IE cut mode, the cortex is brought out as well from within the pupil. And finally, as long as you have a stable rhexis, then a three-piece IOL through this enlarged incision can be slid into its place into the ciliary sulcus. These are safer lenses to have. A single-piece lens is likely to cause inflammation and glaucoma and should not be done. And clearly, you need to suture this incision because it's not a stable incision. Let's come to the third case. Now, here's a colleague of mine who is performing a hydrodissection. And notice what happens to the pupil because when the Chetter fluid goes in, you can notice a sudden snap in the pupil. A snap in the pupil signifies that there is a blowout of the posterior capsule. At this point, ideally, we should be converting to SICS because you don't know the extent of the blowout. The surgeon chose to continue with phaco and suddenly notices that this was not a good idea and the nucleus is tipping to dip downwards. So at this point, the first plan is to bring the nucleus up into the safe zone. Now, if the nucleus is just dipping slightly in the anterior vitreous, you can still try and bring it up into the anterior chamber. Now he has to convert, but because he is a temporal surgeon for phaco, he chooses a completely different site. He shifts superiorly, and now makes a brand new tunnel, completely bereft and clear of the phaco tunnel, which was temporally seen. And this is a dissection of the manual SICS tunnel, as you can see happening. I think personally having either a tunnel and a phaco incision at a different site, or at least at a different level, to be able to achieve a stability of the SICS tunnel, there's wisdom in that. Once the tunnel is extended, the nuclear fragments are navigated out into the anterior chamber, and then with visco or with the help of a Sinskey hook, brought out of the eye. And as I showed you in the previous two cases as well, a limited anterior vitrectomy almost always needs to be done in order to enable us to clear all the vitreous from the anterior chamber, first from the wound, from within the wound, from the anterior chamber, from the area of the pupil, and finally in the area of the rent. Sometimes while performing a vitrectomy, as in this case, fragments float up. If they do, you never go chasing them, but if they do float up, you can bring them up into the anterior chamber and bring them out. Here you can see we are continuing with the limited anterior vitrectomy, and upon the completion of the vitrectomy, now that you already have an enlarged tunnel, with significant ease, a three-piece IOL is slid in the correct position in the ciliary sulcus. I prefer these lenses even to PMMA lenses. They give you adequate stability. Now here's the same surgeon friend of mine who, in this particular case, was performing a scleral tunnel phaco, in a patient with a NS2 with a polar cataract. Now the story can be a little different when you're performing a scleral tunnel phaco. Here, while bringing the last fragment, the surgeon has had a rent. So now, if you were to enlarge this to put in a lens, should you choose to put in a three-piece lens through a larger tunnel, now it's fine because anyway, the incision is scleral. You can give back cuts, and you can then extend this into a SICS tunnel very easily. And I think this would be the biggest advantage of doing a scleral tunnel phaco, in my opinion, because it's very easy to not making any other tunnel in any other place. It can very easily be converted to an SICS tunnel, as you can see here, with just virtually extending it slightly on the side with two back cuts. And then with the same, he didn't even bother changing to a 2.8 keratome. He's enlarged the section enough to allow for the IOL to go into the ciliary sulcus. Again, tricot is used to confirm the absence of vitreous. The excess viscoelastic is removed from the eye, the side ports hydrated, and the wound closed. Here's another case. This is my very talented fellow who's going to remove. So now this is another question. What if you need to remove an IOL that's implanted with a broken haptic? There are various techniques to maneuver an IOL into the AC, but I find all of them do cause some amount of corneal trauma. We chose to enlarge the section for the same. There you can see was the phaco tunnel, which I highlighted. Now, obviously, you want to just remove a foldable IOL, so you don't need a very large tunnel. I'd like you to notice how this surgeon actually joins the two tunnels together most elegantly. It's not my preferred technique of choice, but it's his, and it's worth demonstrating. So he starts at the same clock hour, because that's his preferred position of ergonomic ease, both for phaco and SICS. But while he dissects the tunnel out and moves from the left end all the way up to the area of the phaco tunnel, notice how he blends it into the phaco tunnel. And having done so, now navigates, finds his way to the other end of the phaco tunnel, and then extends the tunnel further into the cornea and then into the sclera, very elegantly joining both the phaco and the SICS tunnel. Viscoelastic always needs to be used intermittently in these cases to be able to giving you the adequate fixity to be able to not only dissect the scleral tunnel, as well as to get a clean opening when you're entering into the eye. Once the tunnel is enlarged, then the IOL is hooked upwards. Again, viscoelastic is introduced into the eye, and with the help of McPherson's, the IOL is extruded from the eye, after which another lens is implanted with ease into the capsular bag. There is no problem with the capsular bag here. We only had a broken haptic. At the end of that, the excess viscoelastic is removed from the eye. Notice that the phaco tunnel and the SICS tunnel look very, very well opposed. They are clean, and there doesn't seem to be any problem in joining both of them together. This brings us to the end of this case. And finally, I come to the last case of my series. This is a private patient who came to me for a phaco. He came a week later. He came a week earlier with the NS3 nuclear sclerosis, and a week later with an intermittent cataract. Being a left-handed surgeon, I planned for a phaco because it was a soft intermittent cataract. But the minute I put in blue dye and then washed out the blue dye and put in viscoelastic, I noticed that this lens was very mobile. And as you can see, it was actually subluxated slightly anteriorly between the 6 and the 12 o'clock position. Knowing that there's no way I'm going to be able to complete this case with phaco, I called my VR colleague and he said, just get the lens out, hand it over to us, we'll complete the case and do SFIOL. So this is my phaco tunnel. And me, as a superior sitting surgeon, I performed a peritomy, and then I create my SICS tunnel. I make it again superiorly, but what I do in this particular case is, again, I do not join both together because I don't like to join both the tunnels. And after achieving an adequate hemostasis, I then proceed to making the tunnel. So I think we all have to be equipped with the skill sets of being able to convert from phaco to SICS. I think we shouldn't wait till a disaster happens to manage to plan how you want to make your incision for the first time. Based on this webinar and any other surgeries that surgeons have done in the past, it's worth defining for yourself what is going to be your technique of choice, because when disaster strikes, we've got to act fast. We've got to know how we want to complete the incision because we want a self-sealing tunnel at the end of the surgery. For me, I was very happy to make it almost at a completely different plane. Then I went ahead and enlarged the tunnel. And this was a very intermittent subluxated lens. I didn't even know how to get around it, to be perfectly honest. So first I tried with just one instrument, as you will see. Under an adequate viscoelastic cover, I put in some dispersive viscoelastic to see what was going on and how mobile this nucleus was. Then I tried with the Sinskey hook to go behind it to lift it up. And having managed to lift it up superiorly, then I put in some more viscoelastic in the anterior chamber. Then I slid a Sinskey hook deep to the nucleus. And then with having stabilized the nucleus and elevating it out into the anterior chamber, I put in some more viscoelastic because I now don't want to damage the anterior the corneal endothelium. And then I use a second instrument Well, I managed without the second instrument. I just hooked the nucleus out. But unfortunately, the anterior capsule has given way. The nucleus is out, and with the help of a McPherson's, I try and hold on to the capsular rim and bring it out of the eye. But unfortunately, I have some amount of the soft cortical nuclear remnants there. I perform a scissors vitrectomy. I suture the wound and hand the case over to the VR colleagues, who then take over the case immediately, perform a limited vitrectomy or probably a pars plana vitrectomy and an SFIOL. And this is the series of cases that I wanted to discuss with you, highlighting the kind of incisions we need to take and highlighting how we need to be ready to act fast when faced with a disaster which we need to avert. Thank you.
Thank you, madam, for a wonderful presentation. And as you said, it's really difficult. Once Paco fragments are there, it is very difficult to remove all the fragments than removing the whole nucleus through the incision. But I'm sure that in your hands, it's very simple, as everybody knows.
No, it's not that simple. It's always a challenge, no matter how experienced you are. But I think it's very important to understand, if I'm faced with this, what am I going to do? We should be practicing it on goat eyes or on human eyeballs, which are this, and devising a technique of extending the tunnel so that both the phacoincision and the SICS tunnel remain, safe. And a VR standby, an automated anterior vitrectomy. And yeah, I guess that's what I wanted to say. So
thank you, madam. We'll be taking question answers at the end of the session.
Sure.
So may I invite the second speaker, Dr. Deepak Megur. He'll be speaking on aborting phaco, conversion to SICS, my top tips. Over to you, Dr. Deepak Megur, sir.
Yeah. Thank you, ma'am. And I'm audible, right? My screen
Yes,
is audible? Yeah. So thank you, Dr. Anil Shah, for having this. And it's really, truly inspiring. You are conducting these series for the last 3 years, I guess. And it's one of the most informative and educative forums. And thank you for having me here. So I'll be learning a lot along with all of the other audiences here. So I'll be speaking on how to convert to SICS when faced with a situation where we are forced to abort phacoemulsification. So let us see this case.
Knowledge is good.
So I got these 2 fragments, and then one of the heminucleus is held and the second chop is done. So I have this free fragment which is pulled out of the bag and is being emulsified. At this moment, I get a sense that something is wrong. This nuclear fragment is appearing slightly deeper. Let me check, I thought. I came out, injected OVD, and well, I can see that this fragment is definitely at a lower level. I use my Sinski just to feel it, and it seems that my worst fears are coming true. I'm looking for any visible posterior capsule tear, although the posterior capsule tear could not be made out, but there are all the signs which are definitely suggestive of an underlying posterior capsule tear. And if that is true, then I may be dealing with an impending nucleus drop. So I'm pushing dispersive OVD under the nuclear fragment. I'm just trying to figure out the extent of the PC tear, and I'm trying to maneuver the lens fragment out of the bag. In this process, the thin lens fiber which was connecting the 2 heminucleus, which I had not noticed initially, just snapped. And now I could sense that the smaller fragment has gone still posterior. Well, it is not looking good at all now. The nuclear fragment looks like it is descending down. And at this moment, I'm thinking, should I close the case and let my retinal colleague deal with this later? In fact, I stop everything and thinking for about a minute on how to go about. And then I decide to go ahead and remove at least the anterior heminucleus and then see how things go. So I'm pushing dispersive OVD under the nuclear fragment. Now, since the heminucleus is quite large and bulky, I decide to make a fresh scleral tunnel incision in the superior quadrant. Mind you, I was sitting temporarily for the phacoemulsification. So I shift superiorly, give a subconch lignocaine, raise a small bleb, then make a conjunctival flap, and then using a blunt cannula, inject 1 ml of lignocaine in the posterior subtenon space. Augmenting anesthesia is critical, as I know that this surgery can take some time now. A scleral groove is created, and using a crescent knife, a sclerocorneal tunnel is created. The tunnel is at a slightly deeper plane when compared to this side port incision, which was originally created for the phaco procedure. OVD inside the tunnel demonstrates the nice biconcave structure. The internal entry is done with a sharp keratome, and the sclerocorneal tunnel is extended on either side. As soon as the antechamber is entered, there is a momentary shallowing of the anterior chamber. As a result of this, the nuclear fragments have also moved anteriorly. This was a blessing in disguise. Dispersive OVD is injected under the fragments. One fragment has floated up into the anterior chamber. OVD is injected above the fragment and under the corneal endothelium. Using the sandwich technique, the heminucleus is guided out. The second heminucleus has subsequently moved up anteriorly, and again the same process of injecting dispersive OVD under it is done, and it is maneuvered into the antechamber. Using dispersive OVD under the heminucleus is critical because it pushes away any vitreous which is surrounding it and also acts like a barrier. The heminucleus then from the antechamber is expressed out quite easily. OVD is injected into the eye, and then I turn on the retroillumination mode. It is evident that there's a huge posterior capsular tear. In fact, I'm not able to see any edge of the posterior capsular tear now. The anterior capsular margin is quite clear all around, and there is some cortex yet to be removed. But before attending to the cortex, I need to perform anterior vitrectomy first. I create a side port for the cutter. I'm using the original phaco incision for irrigation. I'm holding the cannula in a slanted way to block the big incisions, so to minimize any wound leak. Well, this is just a workaround to avoid another side port for the irrigation. So I begin my anterior vitrectomy process, and in a couple of minutes, the anterior vitrectomy is complete, and now is the time to remove the cortex. It's important to remember that any remaining epinucleus or cortex has to be dealt with only after the prolapsed vitreous is taken care of. As the cortex is being aspirated, I can see the edges of the torn posterior capsule. Before implanting the IOL, I'm using diluted triamcinolone acetate to check for any remaining vitreous fibril. Well, there are few of them which are then taken care of. I'm using sodium hyaluronate to create some space between the iris and the anterior capsule. A multi-piece hydrophobic IOL is gently slid above the anterior capsule, and the proximal haptic is dialed in so that the entire lens is presently above the anterior capsule in the ciliary sulcus. I ensure this by retracting the iris back and visualizing the haptics above the anterior capsule. Using the retractor, I go behind the lens to remove some of the OVD which has gone behind into the vitreous cavity. Once all the OVD is removed, time to achieve the optic capture. The optic of the lens is gently pushed back posteriorly until we see this ovalization of the rhexis margin, which confirms optic capture, wherein the haptics are in the sulcus and the optic is trapped behind the rhexis margin. The side ports are hydrated. I'm using diluted triamcinolone acetate to check for any remaining vitreous fibril. The superior scleral tunnel incision is sutured with a single 10-0 nylon suture to take care of the pre-existing against the rule astigmatism, and also to avoid any postoperative hypotony, which we see commonly in eyes which have undergone antivitrectomy. The conjunctiva is then closed with etovical suture. It's extremely important for me to finish well. I really want to see the eye look really good at the end. So no matter how long the surgery has been, so finishing well is very important. So once done, this is the next day picture. The patient cornea is clear, the pupil is round, the patient has got an excellent visual outcome. So patient continues to do well. We have monitored her for the next 3 months.
Yeah, the lesson which we learn from this is that, being very skillful with SICS really helps us a lot in such crisis situations. I don't think any phaco surgeon, should, every phaco surgeon rather, should be, having reasonable amount of skill and expertise to do SICS in such cases, because in India, it's lucky because most of us are trained to become SICS surgeons first, and then we transition to phaco. But on the contrary, in the Western world, where they just know how to do phaco, but in such situations, they just don't know how to bail out. So I really can't emphasize the importance of learning and mastering SICS. Few things in this case were worth highlighting is because we are doing a topical anesthesia. When we convert, it's important that we augment anesthesia. We did a subconch injection initially, and then once the flap is raised, you go ahead and do a posterior subtenance with a blunt cannula. That really makes the patient comfortable, and you can proceed. The second thing to note here is that I did not use any superior rectus suture. So many younger surgeons who are used to using the superior rectus for performing SICS, they should be learning or to get away from it, because in situations like this, you should be skillful enough to perform the SICS surgery without using a superior rectus. And it is not difficult at all. So just get it out of the mental block. Number three, in this case, I switched from the temporal incision to a superior incision. I did not have any hope of that second nuclear fragment, which is deep down coming up. So, but at least the anterior one I just wanted to remove. That's the thing. See, the rate at which the nuclear fragment is going to descend down into the vitreous cavity is purely dependent upon the consistency of the vitreous. If the vitreous is slightly jelly-like, it still holds on, and that is, you will have some maybe couple of minutes to perform a scleral tunnel. But if you're extremely unlucky and the vitreous is very fluid and degenerative, it would just drop down in a jiffy. So you don't have any opportunity to go and pull it out. Nevertheless, whenever you convert from a closed chamber technique to an semi-open chamber like your SICS or an ECC where it becomes an open chamber, whenever there is this sudden change in the pressure levels, because it's a semi-open chamber, invariably, without us doing anything at all, the fragments can just float up if they're still hanging in the just behind the posterior capsule. But the message is never ever go with your vectis to hunt for it. That is going to be very bad, because if we induce a giant retinal tear because of the traction which we induce, that is going to be much more difficult to treat as far as the patient is concerned, and the outcomes are much more poorer than just allowing it to drop. Okay, so nucleus drop and nucleus management by the VR surgeon is an extremely easy procedure for them. So don't be over enthusiastic in chasing them. If it is just coming on its own, use only viscoelastic to maneuver it out, nothing else. No instrument is going beyond the level of the pupil. Only the viscocannula, because the visco, when you put it, you're just pushing the vitreous away and then floating the nucleus up. If it is going to come by this technique, you do it. Never ever go hunting with the vectis, because that is going to cause a much more serious problem, and it would be an iatrogenic one. So we should be mindful about that aspect. Now, this is a situation where I I created a fresh tunnel in the superior aspect. The other way around is you can also create a fresh tunnel in the same quadrant. So I'll just like to show you that portion. So this is one of my trainee surgeons who was ended up having a rhexis which is extended. Emulsification in this situation. And the surgeon has made a superior 2.8 millimeter posterior limbal incision, and it is now being taken over by me, and I'm going to convert this into a manual small-incision cataract surgery. So I'm going to proceed with the same superior quadrant. Let me take you through the steps which I'm going to do to have an uneventful outcome in this complicated situation now. The first thing, I'm going to do a conjunctival peritomy, and if surgery is being done under topical anesthesia, it would be better to just inflate the superior conch with local anesthetic before we start doing the peritomy. Once the peritomy is done, I'm going to inject 2 ml of lignocaine in the posterior subtenous space using a blunt cannula under this peritomy under the conjunctiva, so that the patient is much more comfortable and can endure the pain, because the surgery is now going to be slightly prolonged. The superficial bleeding episcleral vessels are cauterized.
My plan now is to make a fresh sclerocorneal tunnel, which would be at a slightly different plane than the original 2.8 millimeter incision which was done in this patient. To fixate the globe, I usually perform small scleral groove. Mind you, I'm not using any superrectus suture in this eye. If some surgeons are uncomfortable, they can always put in a superrectus suture, but that has to be done before doing the peritomy. I'm beginning to make the tunnel just paracentral to the original 2.8 millimeter incision.
Just to highlight here, the plane which I'm going to create is going to be different from the original clear corneal plane. So the corneal stroma, the lamella at which we go, it will be much more, it will be a different plane. So I would not prefer to go and extend the same plane, rather create a separate new plane.
Just to ensure that I don't go into the same plane. So I'm sure that this plane is slightly different from the original 2.8 millimeter incision, and then the tunneling is begun. Fixation of the globe is extremely critical when you're trying to perform the sclerocorneal incision. So as I'm...
See, here there is no superrectus suture. So, you should have a perfect way to stabilize the globe. This is my technique of creating a fresh posterior scleral groove and then gripping it. But if you have any other way of gripping the eye, it's all right. But because the secret to performing the tunnel is to have a good fixation. Now, especially if the eye is soft, then you'll have much more problem. So that's the reason why have a good pair of forceps. A limbs forceps would be one good choice. Fixate it well and then perform the tunneling.
Performing the sclerocorneal tunnel with a crescent blade. Please note that the globe is held very stable. It's not moving around. So this gives me excellent control. I'm about 1.5 millimeter behind the limbus and also about 1.5 millimeter in front of the limbus as the sclerocorneal tunnel is being fashioned. The width of the incision is about 6.5 millimeter or 7 millimeter. Now, because the chamber is filled with OVD, it's easier to pass this crescent knife when the eyeball is firm. The cutting is much more easier and effortless. So we have created a plane which is either slightly superficial or slightly deeper than the original 2.8 millimeter incision. So far, so good. The tunnel is filled with OVD just to separate out and show me the tunnel. I'm entering the 2.8 millimeter keratome again in an area which is paracentral to the original 2.8 millimeter incision. And then I'm going to extend it laterally to my right hand side to the entire span of the sclerocorneal tunnel. At this point, I'm not sure whether the original plane has been transacted, but so far it looks all right. So the sharp keratome is used to enlarge adequately on either side and it looks to be fine. Time to maneuver the nucleus out. Now, because this is an intumescent lens and also the integrity of the rhexis is not all right, I'm going to use two Sinskukes to maneuver the nucleus out of the bag using the bimanual technique. The nucleus is wheeled out into the antechamber. And under the cover of OVD, I'm going to use the phaco sandwich technique to extract the nucleus out. The dialer goes above the nucleus and the vectis is below it. The nucleus is grabbed in between these two instruments and then the nucleus is pulled out. The soft epinucleus in the cortex is gently irrigated out. There's hardly any cortex which is aspirated out. The bag is refilled with OVD and the planned PMMA lens is then introduced into the capsular bag. Care is to be taken that the orientation of the haptic has to be 90 degrees to that of the tear. OVD both in front and behind the lens is irrigated.
So I think in these two cases, I would like to conclude my presentation. Just a few remarks here. So there are situations where you're forced to extend the clear corneal incision, like the case which Dr. Suvira was just showing, that in desperation, when the nucleus are dropping down and you don't have enough time to even convert to SICS, to scleral tunnel. Maybe you're justified in just extending the incision, but I would do it only when we're dealing with smaller fragments, not a large fragment. You can just enlarge and then under the cover of viscoelastic just express them out. Because we don't want to enlarge the same corneal tunnel simply because it's going to induce much more severe astigmatism. We need to suture them. The astigmatism is going to be uncontrolled. We can't predict it. So the bottom line is the visual outcome would not be as good as when we do a planned scleral tunnel incision. So the first choice always is going to be perform a scleral tunnel either in the same quadrant or 90 degrees to be away from it. But in the worst case scenarios, we don't have enough time. That's the only situation where we would like to enlarge the clear cornea. I think with that, I'd like to conclude. Thank you for thank you for the opportunity.
Thank you, sir, for the amazing series of videos. It's always a treat to watch your videos. So coming to the next speaker, Dr. Pradeep Mohanta will be speaking on FACO to SICS, making the right move. Over to you, sir.
Yeah, am I audible?
Yes, sir.
Anil Shah sir, can you share my videos?
Sunil, hello.
Yes. Converting to SICS,
Sunil.
making the right move. In this case, FACO was planned, incisions have been made, the anticapsule is stained with trypan blue dye, double X is planned, but see what happens. I attempted to make a C flap, but Argentine flag sign is seen. Experts may proceed with FACO in such cases, but the right move is to convert to SICS because there are two weak points. One of those can extend posteriorly and there can be vitreous prolapse and lot of other complications. So the right choice is to convert to SICS. Peritomy is done between the two incisions, the main incision and the side port. The cataract is grade 3 plus, so at least 6 mm incision is made, a mild frown incision. A crescent blade is used to make the tunnel, and the tunnel is completed. Rhexis is already done, so we just have to prolapse the nucleus and deliver the nucleus. Whenever there is extension of the rhexis, run out of the rhexis, this is the tunnel is being opened. Whenever there is run out of the rhexis, I usually prefer fish hook to deliver the nucleus. The nucleus is prolapsed, the fish hook is taken, the fish hook is made with the, just bending a 30 gauge needle. It goes behind the lens, turns and hooks the nucleus out of the eye. This is another case, hard cataract. The cataract is grade 4 plus and rhexis was going nicely, but suddenly the rhexis runs out at 7 o'clock and it could not be, retrieved. In this case also the right move is to convert to SICS. Since this is a hard cataract, the tunnel length should be at least 7 mm. Mild cautery is done. We may not do cautery. In those cases, the assistant has to pour in the saline or ringer lactate. The tunnel is made, incision placed, a crescent blade is used to make the tunnel. Making the right tunnel is one of the most important steps of SICS. If we hurry up, we may cause lot of problems like premature entry, very thin anterior wall of the tunnel. So to make the right tunnel with good corneal valve, we have to dedicate some quality time. So the tunnel is made. This is the incision size is about 7 millimeter. The nucleus is prolapsed. Again, I prefer the fish hook to deliver the nucleus. It goes and the nucleus is easily delivered out of the eye. And cortex is cleared and a lens is placed in the bag. The bag is, good. There is good amount of anterior capsular rim, so the haptics are placed behind the anterior capsular rim. There is no PC rent, so the lens settles in the bag nicely. And see the beautiful post-op picture after 24 hours. No corneal edema, antechamber quiet. There is very nice apposition of the conjunctiva to the limbus, and patient gets 6/12 vision unaided. This is another case. In this case, there is fibrosis of the anterior capsule inferiorly. So as I try to do the rhexis goes nicely, but at around 6 o'clock or 6:30 o'clock, there is fibrous band and the rhexis goes to far periphery. So if I try to pull it, I can detach the zonule. It can cause a lot of damage. So I take a scissor, micro scissor, cut the capsule, complete the rhexis, and convert to SICS. Pupil is becoming small, but once we convert to SICS, that is much safer even if the pupil becomes small. The nucleus is prolapsed in the anterior chamber. Viscoelastic substance is injected both in front and behind the nucleus. And now again I use the fish hook. The nucleus comes out very smoothly. Cortical cleanup is done and an intraocular lens is placed in the sulcus. In this case, I took a PMMA lens and placed it in the sulcus. This is a 6 millimeter PMMA lens, and the lens goes in the sulcus. And the patient did very well in the postoperative period. This is the postoperative pictures. There was very mild corneal edema. And this is the last case of this presentation. Posterior capsular rent has occurred and this heminucleus is still remaining. So I convert to SICS, make the tunnel and inject visco on either side and try to do visco expression. Visco on either side, both right side and left side of the piece. Press the posterior wall and the piece comes out. So visco expression was done for this heminucleus. A multipiece lens sensor, multipiece lens is placed in the sulcus. In such cases, we must check if there is vitreous prolapse in the anterior chamber. triamcinolone acetate is a very nice thing to detect any vitreous strand. This triamcinolone acetate molecules sticks to the vitreous strands, and we can easily identify the vitreous strands. And whenever there are vitreous strands, we can see the vitreous strands coming out from 7 o'clock. So I take the vitrectomy cutter and shape the vitreous strands. We can even go behind the lens and do some cleaning of viscoelastic substance that goes behind the lens. A nice anterior vitrectomy is done, and when you do a nice anterior vitrectomy, you get very good result. And whenever there is posterior capsular rent, we should suture the wound, even if the wound appears very nicely sealed. And this is the postoperative picture. The patient got 6/12 vision unaided, and the patient was happy. Thank you very much for your attention.
Thank you, sir, for a very lucid presentation. And as you rightly pointed out, that every surgeon has to know his limits, and timely conversion from FACO to SICS. It decides the post-op results. Thank you so much. Coming to the next speaker, Dr. Chinmay Sahu. He'll be speaking on post-FACO to SICS. Over to you, sir.
Thank you, Anisha, sir, for giving me this. Am I audible?
Yes, sir.
Yeah, thank you for giving me this opportunity to share my experience today. The previous speakers have beautifully highlighted the various situations where we can convert to SICS. Before I jump into a couple of videos, I would just like to lay out certain points. So a conversion to the SICS can happen in two ways. It can be a planned conversion or it can be an unplanned one. A planned conversion typically is when you're dealing with complicated situations like a brown, black, leathery cataract where you anticipate, a nucleus drop, a case of zonular dehiscence where you're not sure whether you can go through with a capsular tension ring, capsular tension segment, and as a backup, or where you are anticipating a PC rent in certain grades of posterior polar cataracts. At times, even cases where cornea, the endothelium is compromised, like a Fuchs dystrophy. Unplanned cases can be, as it has been beautifully highlighted by the previous speakers, where brown black cataract where the phaco is not going as planned, a zonular dehiscence case where you have PC rents and wherever there's a rexus extension. Now, when extensions happen, all SICS would obviously be a better choice because of better chamber stability, lesser chances of progression of the primary pathology where, for example, a rexus extension or a PC rent, and for better refractive outcomes. Now, I'll just jump to the video out here. I would be like keeping it brief. There are two videos. The first is a case where we are having, this is a brown black cataract, and when I deal with such cases, the temptation, primarily being someone who's doing primarily phaco surgery, the temptation is to go ahead and do the phaco. But I also am quite wary of damaging the corneal endothelium or landing up with other problems. So in such a situation, you can go ahead and plan a scleral tunnel. Now, here I've done a 6 to 7 millimeter incision, which is around 1 millimeter away from the limbus. And rather than just doing a small scleral tunnel where I have created a larger incision and created the entire tunnel, so that in case for whatever reason, if I'm unable to go through with my surgery, I can then enlarge the tunnel and make a larger entry and take out the nucleus. Now, depending on the experience of the surgeon and whatever technique they are comfortable, it can be a straight incision, a frown incision, a straight incision with back cuts. Even the size of the incision can be reduced if the operating surgeon is comfortable with various delivery techniques of ability to crack the nucleus in the anterior chamber and bring it out through a smaller incision. As I primarily do phaco surgeries, and my comfort lies in creating a large enough tunnel where I can easily express the nucleus out of the anterior chamber. Now here I've gone ahead and I have made the entry. I'm using a chopper to try and chop the nucleus. Now what's happening is I'm creating the chops, but as you go through with the surgery, all that is happening is I'm getting stuck and I'm unable to complete. And I get to a point where I start feeling that in this case, it's better for me to abort and convert to the small incision cataract surgery. Now, because there is a smaller incision cataract surgery being planned, the next point is the rexus should be adequately large. Typically, if you are planning a phaco surgery, you would want the rexus to be overlapping the edge of the optic. But in this case, because there is a possibility of converting to an SICF, I have planned a larger rexus. Now, how do you dial? For most of the people who do a large volume of SICS surgeries, this may be a no-brainer. But still, for certain beginners and for those who are kind of looking to convert, you can either use the Sinskey hook and try to use two Sinskey hooks and dial it into the anterior chamber. If you're unable to do it easily, you can kind of use the tip of the 26 number needle, engage the nucleus, and then try to rotate it and manipulate it into the anterior chamber. So here, because now already it's not easy because it's not a single nucleus. It's been kind of manipulated. I'm using depressing the scleral tunnel to again remove it from the anterior chamber. As shown by previous surgeons, visco expression or using a vectors or the fish hook technique which Dr. Mahanta showed beautifully. Whatever technique works well in your hand, ensuring that in this case, for example, there was no PC rend. So it's critical that we maintain the anterior chamber inflated adequately with visco, protect the endothelium. At the same time, we don't land up rupturing the PC, while everything is going smoothly. So here I have removed the lens from the anterior chamber, and I'm going to go ahead and just implant the lens right now. So this was one case where there was no complication as such, but you can get stuck when you're doing brown cataracts, especially when you're in a phase where you're evolving as a phaco surgeon, where your techniques are not completely matured. There are situations where brown cataracts can become challenging, and planning a SICS tunnel and trying to have a backup of that can be a really useful thing. Now, this is the second situation where I have a problem during the surgery. Now here I start doing, and if you realize at this point, I can see a flap of the inferior rexus. It starts fluttering, and I realize that now I'm in a bit of a soup. I then try to salvage. I try to give a snip to the inferior capsule to see whether I can, just give a cut and proceed with the surgery. After having done this, unfortunately, like in previous surgeries where Dr. Manta has shown, if you have a mature cataract, you've stained the capsule, you can see the edge of the rexus, well, you can try and salvage it. In this particular case, the cut end is not that well visualized. And I'm not confident that, have I done it properly? Still, I'm tempted to go ahead and complete my phaco. I try to initiate the chops, but again, at the back of the mind, the fear is that I might catch the cut end of the rexus or the flap in the phaco probe and cause extension and land up with a PC rend. So at this point, I decide that it's too risky and the plan is to convert. Now, whenever you're caught in a situation like this, depending on your comfort, as beautifully highlighted by the other surgeons, if you have an option of taking the scleral tunnel 90-degree away from your primary incision, it's great. Now, in my case, since I rarely do SICS, I'm most comfortable doing only a superior SICS tunnel. And in this case, since the corneal tunnel was already superior, as shown by previous speakers, I have gone and created another scleral incision and tried to go at a deeper plane. So now Dr. Deepak has beautifully showed that you can either go, at this point and go give a posterior subtenon. The important point is, yes, as he rightly mentioned, that you have to have adequate anesthesia. If you do not do that and the patient is squeezing the eye unnecessarily, you might land up with a problem. Either you can go and give a posterior subtenon, which is the simplest thing to do. At times, it may not give you adequate akinesia, and that's the what you need. You can just remove the speculum and go through and give a peribulbar, and then again go back and continue the surgery. Then between when you create the scleral tunnel, my preferred choice is to go to a deeper plane and to create a different tunnel altogether. Rather than, as Dr. Suvira has shown in one of the videos where one of the surgeons has elegantly actually kind of merged both the tunnels. However, when you're trying to express the nucleus out of the anterior chamber, at times it may not come out that smoothly, and it's far better to create a deeper tunnel. After that, again, in this case, because I've had a rhexis extension, I consciously try to, dial it first in one direction. I have brought it into the anterior chamber. I am worried at this point that I should not create an extension of the rhexis. So the tip is to actually inflate the anterior chamber go behind the nucleus, inflate it, and also, dial in the opposite direction so that you're not leading to a further extension of that rhexis out there. After having delivered it into the anterior chamber, I go ahead, I depress the nucleus, and as you can see, since it's in a deeper plane, it kind of smoothly comes out of the anterior chamber. In this particular case, I go ahead and I implant a non-foldable lens in the sulcus. I didn't have the backup 3-piece lens for this case, and I did have a non-foldable lens, which is what I did, and I've implanted in the sulcus. Since I'm not sure about the stability of the incision, I have gone ahead and I have taken 2 interrupted sutures and I have sutured. It's far better to be sure about that. So these are just 2 videos that I wanted to share. Thank you for your patient hearing.
Thank you, Dr. Sahu, for excellent presentation. So basically, we have to convert from phaco to SSS whenever there is nucleus drop, PC rent with or without vitreous prolapse, or sometimes there is sonular dehiscence. Very rarely in case of novice surgeon, because of excessive corneal damage, you have to convert. So how and at what stage you convert decides the post-operative success of the surgeon as well as the patient's vision. So after this engaging 1 year of auditory and visual treat, may I now request my co-moderator Dr. Pankaj to invite the discussants and invite any questions from the panelists and the audience. Over to you, Dr. Pankaj.
Thank you. Excellent videos and cases by all the esteemed speakers. Really very nice presentations, many take-home messages. And let's hear from our discussions first. I would like to hear from Dr. Manisha Rathi, madam. Can you please?
Wonderful. Thank you so much for having me here. I was wondering how long this is going to go, but this has been such an enjoyable evening. We actually didn't know how the time went. All the presentations were par excellence, and it takes a lot of guts to show the complications which occurred, which actually people learn from. So a lot of my students also have joined as audience online, and I'm getting feedback that this is a very good webinar and very good presentation. But Maharashtra Society, you always outdo yourselves. So thank you so much for this. Just a few observations. What is common in all of them, like Dr. Deepak also mentioned, stop and think. be calm. Take a few breaths and decide what you're going to do, where you're going to make the incision, how big it's going to be. Augment the anesthesia. Make sure the patient is comfortable, then you are comfortable. And the other thing, the flap should be adequate to allow you to give a posterior incision. Then, can I go just case by case? I've written a few points down, so I just want to highlight. Dr. Suvira had excellent videos, a series of 5 videos, and really amazing management in every case. And for the people who are still learning, it's not as easy as it looks, but they were beautifully managed. So in the first case, she had made a beautiful tunnel. There was the correct decision of an early conversion. When you convert early, the post-operative astigmatism, the post-operative result and visual status depends on that. The only observation in the first case was, since an anterior chamber intraocular lens was implanted, could an iris clip lens have been used? Because nowadays we're using that, it's put posterior to the iris and has much less complications than an classic anterior chamber IOL. In the second case, there was the tunnel would have been ideal. It was basically just a corneal incision extent, but of course, the main thing was to remove the nuclear fragments and to implant the IOL. The third case, could the conversion have been done earlier?
Yes.
And in the fourth case, the scleral corneal tunnel for a phaco can be an excellent idea in high risk cases. So that was also a wonderfully highlighted point. Then the fifth case, the merging of the tunnels, very interesting. Although everyone was saying we go at a deeper plane for SICS, but it was handled so beautifully. So finally, it is up to the surgeon how they do it. And Dr. Suvira, case 1, 5, and 6 had beautiful tunnels. So, and 1 and 6 are yours, I know. So just extremely beautiful videos and wonderful to watch, and how coolly and calmly you've handled it, and of course expertly. The only thing is, in the sixth case, the blue dye, a very small point, could have been put under an air bubble. Sometimes we see endothelial staining with the blue dye when we use it. And of course, you have to use an adequate amount of blue dye. Should I go on to Dr. Just give all my comments for everybody?
Sure, sure.
Yes. So
Yeah, you good.
for Dr. Deepak, yes, of course, beautiful scleral tunnel, augmentation of anesthesia, very nicely explained. And another important point was that after dealing with the vitreous, the rest of the cortex is aspirated. That's very important. People start tugging, the people who are still learning, they start trying to remove the cortex, doing a cleanup, and the vitreous keeps coming into that. So that was also a very valid point, which we normally do, but to emphasize it is really wonderful. And of course, to visualize the haptics in such cases after the PCIOL insertion is also very important. Retract the iris, visualize the haptics. And the only thing is, we can discuss later about the suture. It was such a lovely tunnel. I don't know whether you need it to, because then the post-op astigmatism, it's all about surgically induced and surgically corrected astigmatism. But I guess in these cases, when you could have a potential nucleus drop, so it's much better to manage the complication and to insert the IOL. The other thing, the post-op pictures were very good. So showing the post-op results also really encourages students to learn. In the other patient, again, you had shown I mean, like that you were discussing whether superior rectus suture is important. It's very comfortable when you're beginning to put a superior rectus suture, but sometimes when we do a temporal incision, we manage very well without it because the exposure is good. We get a lot of advanced cataract with sunken eyes. In those cases, I would definitely recommend a superior rectus suture. So it's not like you swear either way by it. And the different sites that you choose is, of course, a choice, and most people find it very comfortable because they feel that it is a different plane anyway. And can we extend with the crescent? Because initially, when people try to emulate you and do it with the sharp entry keratome, we can have problems like Descemet's membrane detachment, which we've seen. And Dr. Pradeep, again, I mean, like all of you are really very skilled, and it's a pleasure to watch. So another thing I said, in your first patient, it was converted at the right time, absolutely, and again enlarged with the crescent instead of the knife with the keratome. Then in the second case, could an MSICS have been planned at the very beginning? In all the high-risk cases which we encounter in our experience, maybe we can plan, or the second step we can do through, the phaco through a sclerocorneal tunnel. Especially in hard cataract, can we plan for it? And of course, post-op pictures were very good. Then, yes, another important point that Dr. Pradeep said, do not run after a runaway rexus. So that was also very important. Stop and manage. Then the cleaning behind the lens of the viscoelastic was also very nicely done and very important. Again, the suture is debatable because I feel that even if you don't, of course, do not compromise, but those tunnels which we were seeing are really good, and post-op pictures are very good. Dr. Sahu, of course, you're a vitreoretinal surgeon as well, so you're not scared. Your expertise was showing, and you highlighted planned versus unplanned surgery. Then you also said that sometimes we make a sclerocorneal tunnel in a planned phaco, which again, the others were also emphasizing is a wonderful thing to do. And of course, a larger rexis in the harder cataracts. And a well-stained anterior capsule would be very helpful. Then you, of course, you also augmented the anesthesia. Thank you so much. It was an absolute treat to watch you all. Thank you.
Thank you, madam. Thank you. So nice points we have been taken and have pointed out all the things and just like summarizing all the cases in one go.
I
I
was
would
taking notes. I was taking notes.
most attentive, I think, to have. I would
That was
invite
the
Dr. Divya, madam,
that was
please.
the real teacher, professor.
Yes.
Yeah, I think after Dr. Manisha Madam's, expert comments, I'm wondering if, my notes actually make any sense now. So yeah, just to so one tip I would say is using adequate viscoelastic before you remove the phaco probe. When you know there is a PC rent or when there is PC dehiscence, I think it is mandatory to actually inject visco and gently come out, and not just come out all of a sudden, because that can actually cause sudden decompression and your nucleus can drop. So that is one tip that I would tell all the beginners. And again, when you're a beginner or a surgeon in transition, when you know that you're going to have some kind of a trouble or you're anticipating a nucleus which can, give you a trouble, then it's always good to go with a limbal or a sclerocorneal tunnel. So you can plan accordingly. Again, if you're going to plan a sclerocorneal tunnel, like what you would do in a regular SICS case, then your phaco probe that travels will be much longer. So it is good to go almost close to the limbus and make it adequate enough. Or you can also make a sclerocorneal tunnel and just enter with a 2.2 or 2.8 millimeters in case you need to convert it later. So that, that actually doesn't give you the hassle of actually doing it later once, you have the tunnel entry and all that. So your tunnel formation will be much better. But these are in situations where you're anticipating a problem, like in Dr. Sugira Jain's case, where, she anticipated a tilt of the nucleus, or, when there is zonular dehiscence. In such cases, this can be quite helpful. And removing small pieces when it's a hard cataract, it's very easy to remove them. If your pieces are going to be very soft, then it's definitely going to cause cheese wiring, so that you have to be very careful when you're teasing it out of the tunnel. And using tricot is again a brilliant idea, because it gives you good visualization of the vitreous matter. And doing a good vitrectomy, thorough anterior vitrectomy is crucial again, because you don't want any tug on the vitreous. And merging tunnels, I do it sometimes, as one of the surgeons were mentioning, when you were anticipating the nucleus to drop, when you want to convert it immediately, you can do it, but always make sure that your tunnels are sutured. Never shy away from applying a suture. It's okay. There's no ego here. There's no harm in actually doing it. And again, cortex aspiration, you can use a Simcoe probe. There's no necessity that you only have to use an IA probe to do the cortex aspiration. You can always use a Simcoe probe whenever you're comfortable using it. Using subtenon's anesthesia, again, is a great idea. And for stabilizing the globe, if you have not taken the superior rectus suture initially, you can always hold it at the limbal area. Never hold the conjunctiva, because you're going to tear it. But if you're going to hold it at the limbal area with a part of, hold it well with your forceps, then it's going to give you much more stability. I think that's what I wanted to say. Thank you.
Wonderful, madam. Wonderful. Nice. And all the points which are almost the take-home messages for all of us. I invite Dr. Anand Pangarkar, sir, now. Please, sir, to have your words of wisdom. Dr. Pangarkar, sir.
Even at the cost of repetition, I would say excellent talks, excellent videos. The only thing that I would to add from my point, because I'm not such a great surgeon as these three people are, or four people are, I first of all, before I start, whether there is a possibility for me to convert. In that case, I do a sclerocorneal tunnel and a large tunnel, larger than 2.8 millimeter, but the opening is only 2.8 millimeter and trifid. But all these cases where there is a grade 4, grade 5 cataract, spoliation, some zonular dehiscence already noted, a very small pupil, where I have my own doubts whether I will be able to complete the phaco or not. Second thing is, the success of your conversion to SICS is not to give rebirth to a dead person. You can use an SICS.
Sir, you're not audible, sir. Not much.
You can salvage the situation with good results, provided you take the decision a little early. Third point, good point is that once you have made a big, large opening, 6 millimeters, 7 millimeters, and if you inject adequate visco behind the nucleus fragments and just open the tunnel a little bit, the nucleus fragments will move forward into the anterior chamber from where it is easy to remove. A point of caution I would like to add is about the insertion or implantation of the IOL in case you have had PCR.
Sir, we are unable to hear you, sir.
Audio.
I think you close your video and then I just have your audio on, sir.
And I don't know, I'm able to hear. I'm able to hear it perfectly. I don't know.
We are able to hear.
Yes, I'm able to hear. Yes.
Yeah, we are able to hear properly.
We are able to hear perfectly.
Go ahead, sir, go
Yes,
ahead.
sir.
Okay, then go ahead.
Okay, the last point.
Little louder, yeah.
The last point is about the implantation of an IOL after you have done all this and you have noted a large rent. Do not implant the lens in one go. Get the lens into the anterior chamber. See to it that the leading haptic is above the anterior capsule and then gradually dial. Otherwise, it will go through the rent and give your VR surgeon a chance to remove it. Regarding the sutures, I would definitely advise putting a suture, because if you have done an anterior vitrectomy, the pressure, which is very essential to close sclerocorneal tunnel, will not remain the same. So it's better to put a suture. You can remove it after, say, 3 weeks, in case you are finding that the post-op astigmatism is too high. So don't shy away from putting a suture. One more point is about the size of the victus. For removing the fragmented nucleus, you need a rhexis with a smaller dia, so that the fragments don't go through the victus. Otherwise, excellent videos, all points covered. I don't think I need to add anything more. I hope I was audible. Thank you. Thank you very much.
Thank you, sir.
Sir. Now I would request the chairpersons for their quick concluding remarks and take-home messages. Dr. Rahman, sir.
Thank you. First of all, I must grateful to Maharashtra chapter for inviting me as a chairperson in this great webinar. And all the 4 speakers, Dr. Suvira Jain, Deepak Megur, Pradeep Mahan, and Dr. Sigmay Shah, they have nicely presented. And they have shown the crisis moment during the cataract surgery, where we need to convert in SICS. And it's a very good learning for all the ophthalmologists. And I think all ophthalmologists should know SICS. And it's a very good, safe exit for the surgeon and also for the patient, and to save the cost of vision. And in all this presentation, Dr. Suvira Jain, she has shown very nicely the PC rent and the subluxated lens, how we can manage it by SICS. And Dr. Deepak Megur, PC rent done during the phaco chopping. And the most important thing is that if suddenly the anterior chamber is become deep, and if there is a black hole in the posterior capsule, then there is some doubt that some precedent is there. And sometimes the people become small. And during that period, we should stop the phaco and we should very cool and carefully manage. And Dr. Deepak Megur, he has shown very nicely how the tunnel is making and how the bimanual technique to remove the nucleus, everything he has shown. Dr. Pradeep Mahant, he has shown this extension of the capsule during phaco. Argentina flag sign due to high lenticular pressure. He tried to do double axis, but still it became radially extended. In all these situations, very nicely they have shown by SICS how we can manage it. And lastly, I think Dr. Chinmoy Shau, he has shown the both planned and unplanned. Sometimes we need to keep in mind to do planned SICS before attempt to phaco. In case of black cataract, very hard and sticky cataract, we should not try for the phaco. And during the rhexis may radially extend or the rhexis margin, sometimes it become injured by the phaco teeth. In that case, very nicely has shown how to manage it. So finally, I want to say SICS is a very good option during the crisis period, both for phaco surgeon, both for ear surgeon, and both for glaucoma surgeon. So all ophthalmologists should learn SICS. I am not saying that SICS is superior than phaco. Definitely phaco is superior, but during your crisis period, it's a best technique to save the vision of a patient and to prevent these complications. Thank you very much. And again, grateful to Maharashtra ISM SICS for inviting me. Thank you all. Good night.
Thank you, sir. Now we would like to hear quick concluding remarks from Dr. Prakash Maradi, sir, and let us know your take-home messages.
I think it was a wonderful webinar. All the presenters, they were very correct in their way to show all those videos. I think it was like entering into each other's territory, phaco and SICS. Most of the times it is only phaco or only SICS. But today's videos were SICS in phaco, or started with phaco and then SICS was needed. I think that was shaking hands with each other. Both the techniques are complementary to each other. Nothing is superior. Phaco is also good and SICS is also good in experts' hand. And there are surgeons that are very good for phaco as well as SICS. So both the techniques are complementary, and today's webinar was very well demonstrated by all the speakers and even the discussants. They have participated in a nice way, how both the techniques are helping each other. So there was wonderful message to each and everyone. All the delegates must have been enlightened, and definitely sharing of this knowledge will be useful in their own practice. Thank you so much.
Thank you, sir. Now I would request Dr. Anil Shah, sir, for his remarks.
Thank you very much. All the speakers have presented very nice videos, and that was very helpful to all of you. The most important thing I wanted to say here is that even a normal cataract can be complicated, or a complicated cataract can become more complicated. So SICS is a helmet in phaco surgery. When you are driving on a two-wheeler fast vehicle without helmet, and if you meet an accident, then that time the complications can occur. So if you have got an SICS as a salvage, then you can manage all types of complication. I'm really very much thankful to all the speakers. They have shown their technique very nicely. Thank you very much once again.
Thank you, sir. Now I request my co-moderator, Dr. Pankaj Shah, to propose the vote of thanks.
Thank you, Dr. Rujita. It was really indeed a wonderful topic. And this webinar has brought out the importance of SICS. No matter how great your phaco surgeon, you have the best of the machines. But the basics, if you have a good SICS, then any tragedy or any accident, you can come out safely with these techniques and the wonderful videos which speakers have shown today. So wonderful webinar. I thank all the chairpersons of this session, the speakers, the discussions, and the wonderful audience who are there today. I thank Entoad for all this live streaming of the webinar, and thank all of you again to be there for this wonderful webinar. Thank you.
Thank you.
Thank you so much. Thank you.
Thank you. Thank you for the opportunity.
Thank you so much,
Thank
all
you.
of you.
Thank you.
Very nice.
Thank you.
Thank you, Dr. Anil Shah.
Thank you. Thank you.
Thank you, Dr. Pankaj.
Thank you, Dr. Anisha, sir, for giving me this opportunity. Thank you.